Hello and welcome to the Global Nerve Foundation Fireside Chat discussing carpal tunnel syndrome, what it is, what it's not, how we identify it, and what we can do about it. I am Shafiq Siraj. I'm a hand and upper extremity surgeon and associate professor at the Department of Orthopedic Surgery in West Virginia University. The Global Nerve Foundation, or GNF for short, started when a group of thought leaders and experts in evaluating and treating nerve conditions identified the benefits of forming a non-profit organization that would focus on improving the awareness and care of patients with peripheral nerve conditions. GNF was incorporated in 2021 and structured into the 4 strategic pillars of awareness, education, research, and advocacy to fulfill its mission of improving the lives of people with nerve problems. Today's Fireside Chat is organized by the Awareness Committee and is intended to educate the public and help patients seek proper care and ask thoughtful questions and make well-informed decisions. Joining me today are Dr. Deanna Mercer, a hand surgeon and professor from the University of New Mexico, Dr. Carpal, an associate professor of physical medicine and rehabilitation and expert in nerve testing from the University of Pittsburgh Medical Center, and Dr. Harry Hoyen, a professor and upper extremity surgeon at Case Western Reserve University and Cleveland Clinic Foundation. Thank you all for joining me today. We're going to start our session with a brief overview video, after which we will share our thoughts with what we know, what we think we know, and common situations and/or questions we get when taking care of patients.
All right. Hi, everybody. My name is Deanna Mercer, and my charge tonight is to talk to you about the anatomy that is related to carpal tunnel syndrome. What are the structures involved? Where is this nerve called the median nerve? So just a little bit about carpal tunnel syndrome. Mainly the problem that presents in carpal tunnel syndrome is numbness in the hand. And the reason that you have numbness in these particular fingers, so typically it's the thumb, index, middle, and half of the ring finger, is because of anatomy. So the anatomy of the median nerve, you can see the median nerve here coming into the carpal tunnel from the forearm. And the nerve actually branches into multiple components that then feed sensation to your fingers that are shown here in blue and red. And when you have, I call it an elephant sitting on your nerve, when you have compression of the median nerve at the carpal tunnel, which is the red circle there, then all of this just wreaks havoc in your hand. You have numbness in your fingers, and you eventually develop pain and weakness, which is quite uncomfortable. So what exactly is the anatomy of the carpal tunnel? So this is an artistic depiction of that, and it's a cross section. So it's like you're looking down the tunnel, you're looking end on, right down the level of the wrist. So kind of like if you're looking end on here. And the white circle here is the median nerve, and it's surrounded by carpal bones. So these are the bones of your wrist. So the base here where it says small bones of the wrist, that surrounds the floor of the carpal tunnel. Then you have 9 tendons in there. So you have 9 tendons, and those are the tendons that power your fingers flexion. So fingers in flexion like this, and also your thumb flexion that does this motion here. And so your ability to make a fist, all the tendons involved in your ability to make a fist are all living in the carpal tunnel. And then of course, there's the median nerve. Now there's another structure, which is the one that is of most interest to us tonight, is a transverse carpal ligament. And this is this dark gray structure here labeled transverse carpal ligament, which is lying right over the median nerve. And then all of the flexor tendons are deep to that. And this is the structure that is the culprit in carpal tunnel syndrome.
So after watching the video, it seems that a lot of it has to do with anatomy. And it seems that's why we get some numbness. And as we heard earlier, it's really an elephant sitting on your nerve and wreaking havoc. So I'm going to ask Dr. Barr, how do you describe the situation with the pressure on the median nerve in the carpal tunnel?
Well, your nerve really has 2 parts. So it has a lining, and the lining helps conduct the response quicker. And then the nerve has an inside part where the actual nerve fibers live. And so typically when you start to get compression, often when it starts, it's just the lining of the nerve, which is good news because that often can heal up. And then over time, the symptoms can progress and start to involve the inside of the nerve. And that's why a lot of times people will start having just intermittent symptoms, maybe like a little numbness at night. They shake it out, then they feel better. And then over time, their symptoms progress because the nerve is getting more pressure on it and actually having some damage with time. And the other thing that's interesting about nerves is that this pressure on the nerve causes some inflammation in the nerve. And that inflammation involves the whole course of the nerve up to your spinal cord. And that's another reason why symptoms can change over time because of the way our spinal cord processes the information it's getting from the nerve that's going through the carpal tunnel. So it's really interesting how symptoms can change over time as your body tries to process and make sense of this. It's like a faulty wire. Your body's trying to sort it out. And your symptoms can change over time as your body tries to learn to process this new information.
Thank you. Thank you. So let me ask Hattie, it seems this goes through stages, and one of the stages includes weakness. So what would tell the patient, what would they notice when they start developing weakness related to carpal tunnel syndrome?
Yeah, Shafiq, thanks a lot. That's a good question because some people, when they have carpal tunnel, have these funny feelings of numbness or tingling, but other ones say, boy, my hand just isn't as strong as it used to be. And I'll put my hand up here for a second here, and it involves this sort of, thumb area as I fade, in and out. And, it's in this part of the thumb where you notice that you just don't have that strength anymore. And it could even be with grip, but it's often with just sort of pinching. And the reason is that same nerve, which Dr. Barr talks about, carries signals that involve the feeling part of your hand, but it also supplies the muscles that are important for the strength. So if that nerve is compressed or doesn't work quite right, then the muscles don't get the right signal, and then they're not as strong.
Excellent, thank you. Let me go back to Karen. We talked about stages, but are there special situations? I've heard, pregnant women maybe more prone. How do you explain that?
Well, there's certain situations that probably make you more sensitive to inflammation and also that can cause more pressure. So for example, a lot of times when people are pregnant, they're holding more fluid, they have more swelling, they'll have more carpal tunnel. We see it more in people that use their hand like a tool. So if people are like smacking things with their palm, that'll put the nerve at risk. If you have certain medical conditions that put your nerve at risk, like diabetes or vitamin deficiencies, then it's more likely to be injured with a compression. So, if your nerves are super healthy, it might be able to get away with a little compression. But if you have some nerve damage from another condition, a little compression can sort of push you over the edge and give you a lot of symptoms.
Thank you. So let me ask Dr. Mercer, as we have heard already, it's all about nerve compression. But we do see a lot of patients coming in, that were told that they have carpal tunnel and actually were tested and they were found to have carpal tunnel, but really they're complaining about pain in the thumb, arthritis, sometimes pain in the shoulder. So how do we distinguish between the two? Some people come in with, fingers that they cannot straighten. When we've heard what it is, can you tell us a little bit about what it's not and why is it so easy to confuse things?
Sure. So there are lots of things going on in the hand, and there are lots of structures that wear out. So we can have compression of the nerve, of the median nerve, as we've been talking about, that causes carpal tunnel syndrome. You can have your thumb basal joint wear out, where your cartilage gets a little thin, and that causes pain. That is extremely common condition. 1 in 4 women and 1 in 6 men have that problem. And so you may have symptoms of what's called CMC arthritis or thumb basal joint arthritis, and people may confuse that with carpal tunnel syndrome. Another area that often gets inflamed and irritated is the radial or thumb part of the wrist here. And in that situation, that's a totally different problem. It's a tendon problem. It's called de Quervain's tenosynovitis. And so again, there's a lot of real estate around the hand and wrist. And so you have to be very careful that what you're calling carpal tunnel really is carpal tunnel syndrome. The EMG nerve conduction study, and Karen would probably be able to educate us way more on this, but is not perfect. And oftentimes you have people with carpal tunnel syndrome that have classic symptoms: night numbness, positional numbness, meaning they're driving, their hand goes numb. They're doing their hair, brushing their teeth, their hand goes numb. And their EMG nerve conduction study is completely normal. You also have people that have absolutely no symptoms, and they actually are coming in for a completely different problem, but because their caregiver or medical provider thought maybe it was carpal tunnel, they got an EMG nerve conduction study, and the study is abnormal. But when you do the physical exam, which is really what we base our decisions upon, is the clinical examination of the patient, right? We use the EMG study as a confirmatory tool. And so, for example, I examine your hand, I determine that you have all the right symptoms for carpal tunnel, and then I send you to get an EMG study as a confirmatory finding, which also gives us a baseline.
Thank you. That's actually an excellent leeway to my next question. I'm going to ask Dr. Hoyen, what are the best clues for patients? What do you look for when they come in with symptoms that may be carpal tunnel?
Yeah, you know, this is the group sort of alluded to this or touched on this a little bit, and it can be pretty varying sometimes, right? Sort of the classic is numbness on the thumb, index, middle part of the hand, but often it's hard to distinguish between whole hand numbness, partial hand numbness, and for some people, we use the word numbness, but then I've had other individuals describe it as tingling or buzzing bees or just something abnormal when it comes to the feeling part. And I think Dr. Mercer said it can be activity related, right? You're using your toothbrush, or you're writing a lot, or you're on the computer a fair amount, riding your motorcycle. And then the last part, maybe with sort of the classic carpal tunnel, is problems at night where you have to wake up and shake your hands out, get into a comfortable position. And I'm sure some of the folks are listening to this have had carpal tunnel, and when you get it, and I've had it once or twice, boy, it's a pretty uncomfortable feeling when it happens, and you just sort of can't get comfortable. We'll let some of the other people describe some of the other symptoms, like can it go up to the shoulder and some of these other problems. But the classic part is that it's that a different feeling in this part of the hand, but it can be kind of the whole hand.
Excellent. Thank you so much. So that moves us on to the next step, which is if we need testing, or the patient already had a test before they come in, what exactly is nerve testing and how it's done, and what do you look for, Dr. Barr?
We use a machine. It's called an EMG machine, and we'll put little electrodes on the skin. So often we're going to be checking different fingers. And so there'll be ring electrodes, or there could be like sticky electrodes we're putting through the palm. And then we're going to give a very mild electric pulse through the nerve. And what we're doing with those stickies is we're picking up how fast the conduction is going through that carpal tunnel. And even though it's not a large amount of electricity, it's right over the nerve. So a lot of times we'll talk about it feeling like someone snapped a rubber band on your wrist. It's an uncomfortable feeling, but typically not a super painful feeling. But if the nerve isn't really inflamed, it can be somewhat uncomfortable. And usually what we're doing is we're comparing how different nerves are conducting electricity in the hand. So we'll compare that carpal tunnel nerve, the median nerve, to your fourth finger with your ulnar nerve, another nerve that doesn't go through the carpal tunnel. Then we'll compare the carpal tunnel nerve, the median nerve, with the radial nerve that doesn't go through your carpal tunnel. And in this way, we're sort of using you as your own normal control. So we're looking for slowing of the response through the carpal tunnel. And we're also looking at the size of response, because as the compression advances, the responses will get smaller.
Thank you so much.
And usually another thing that we're doing is we're ruling out other things it could be. So there might be like a second part of the test with a needle where we're making sure it's not a pinched nerve from your neck or something else common.
Excellent. Thank you. So I guess I'm going to ask a group question. A lot of people are adopting the use of ultrasound examination to look at the nerve. Any insights, any experience doing that? Is it trustworthy? Is it not trustworthy? Is it going to replace the nerve test? What is the thought of the group?
Maybe I'll start a little bit, and I think all this, it comes to the point is that we want to identify people that have carpal tunnel, which is right here at the wrist, right, as we saw in Dr. Mercer's video. And it's important to exclude lots of other things, right? And because carpal tunnel, we haven't really talked about it. It can even feel like it's shooting all the way up in your arm, right? So if a pinched nerve in your neck comes down, the carpal tunnel problems can go all the way up to your shoulder. So the clinical exam, the questions we asked, Dr. Mercer alluded to some of these really, really important questions. And then these testing modalities or things we can do. And the nerve test is one, but something that doesn't involve needles is the ultrasound. And it lets you, or lets us as providers look at the nerve in these different locations. And then I'll let the rest of the group describe what happens when you see a normal nerve and how does that change in carpal tunnel.
Okay, thank you. So the next question is, when do we actually need to treat it? If somebody just woke up one night with, numbness and tingling, should they show up, go to the emergency room, or should they wait? What can they do before they see a physician? Maybe Diana, can you help us with that?
Yes, glad to. So there's lots of different things that you can do before you sort of sign up for anything that's aggressive. One is simple bracing at night. That can be extremely impactful. The braces are ones that basically keep your wrist in neutral position. You can get them at Walgreens or CVS, and that's really the first step in treating the symptoms on your own. I find that therapy is very helpful, and that, the therapists call it nerve glides. And this is stuff that also you can Google online. There's videos on it on YouTube, but it's just things that you can do to help your nerve glide through the zone, and it helps with mobilizing the nerve a little bit. In addition, doing things like not eating really salty foods, because when you go out for Thai food the night before, your rings don't fit the next day, right? You have a lot of fluid retainment because you ate a bunch of salt, even though it's delicious. You can have your baby, right? So delivering or having, ending of the pregnancy, that often leads to resolution of carpal tunnel. But I do not advocate for women living with this during pregnancy, because the worst carpal tunnels I've ever seen are on pregnant ladies with carpal tunnel syndrome. That is the worst, 2 times. That is the worst nerve I've ever seen in my life. And so I do not advocate that you wait if your symptoms are really severe, because there's a good way to treat it. And of course, the basic things like making sure that you don't have undiagnosed diabetes, thyroid problems, all sorts of metabolic things can cause basically fluid retainment, which causes compression or pressure on the nerve.
Thank you. So let me ask Dr. Barr, patient comes into you, they've had the splints, they don't eat a lot of salt, although they like it. And they had other friends who had steroid pills or steroid injections. What's your take on steroids in general, and specifically injections versus pills?
I'm actually not a big fan for steroid pills for carpal tunnel. I think there's a lot of effects of steroids in the body, and I think we're starting to see steroids used for a lot of different conditions. And so people will start to get higher and higher doses. So, they'll get steroids for a pinched nerve in their back, and they'll get steroids for their knee, and they'll get steroids for their shoulder, and then they'll get steroids for their carpal tunnel, and it all adds up for side effects. I think the injections work better. I think it can often get you through if, now isn't the time to get surgery, or perhaps you were going through a period of very heavy overuse and you're able to stop doing that, the things that aggravated it. I think the injections can get you through. I think the concern with the injections is that a lot of times the symptoms will come back.
Thank you.
So it's not fixing your problem.
So let me ask the next question to Dr. Hoyen. We just received a question about ultrasound. What do we actually look for? What do you find on ultrasound when you have a carpal tunnel syndrome?
Yeah, that's a good question, because sometimes you'll even combine the ultrasound with the injection that Dr. Barr has mentioned. It's important to look at or evaluate the nerve up in this area as it goes towards the hand, and it's often difficult to actually see the nerve exactly within the carpal tunnel because of the thickness of the palm. But what we see is that if the nerve is compressed, and we've talked about this nerve compression, and sort of what is it? If the nerve is this size, right, and it goes into the carpal tunnel, and now it's this thin, what happens to the nerve just before it enters the carpal tunnel? Sort of like if a hose is kinked outside, what happens to that hose? It's going to get bigger before it gets kinked, and that's one of the things. And we can see the edge of that compression, we can see the thinning of the nerve, but what we really can see on the ultrasound is how much bigger the nerve gets just before it enters the carpal tunnel. What's nice about the ultrasound is that it also allows you to identify other things that might be involved with the nerve that we wouldn't necessarily expect. So I think that as we go forward, the diagnosis is important. Again, we'll emphasize it's the history, the exam, adding the other tests, the ultrasound, and the electrodiagnostics as well. And we have a couple people that do ultrasound. So if someone wants to comment on other findings or other important things, go ahead.
Yeah, thank you. Any other feedback? Deanna, do you do ultrasounds, or Karen, do you do that?
A lot of my partners do ultrasounds, and I think it is a nice, it's a nice addition. So, ultrasound looks at the way the nerve looks. Electrodiagnostic or EMG, it's how the nerve is working. So they're really a nice partnership. I think the nice thing about the ultrasound, completely painless, you can get it fast. If it's very clear that that's what's wrong with someone, I think it could be a really good confirmatory test. The strength of the EMG is that it's going to rule out other conditions and probably gives you more specific information about severity of nerve damage compared to the ultrasound.
Thank you. So Dr. Mercer, I have carpal tunnel. I've been diagnosed. Dr. Bard looked at the EMG. It's obvious. I've seen Dr. Hoyen. He gave me an injection, but I moved to another town. I'm close to you. What's the next move? I mean, I'm still suffering. What do you do?
You need a carpal tunnel release. And I mean, if the patient is medically brittle or, needs a little bit of time before they can have the operation, I will do injections, but I just don't often do injections for carpal tunnel because it's exactly what Dr. Barr said. You're sort of putting a Band-Aid on, a giant volcano of a problem. And the compression of the nerve is so miserable. You continue to lose strength in your hand. You can't sleep. You can't do anything for a long period of time. If you're like trying to build an addition to your house, or you work as a manual laborer, you can't wield a hammer because things fall out of your hand. You lose dexterity. I mean, it's a bad problem. And so when people present to me and they have all of the things that point to carpal tunnel, then I recommend an operation. And the operation is very simple and straightforward. It takes 3 to 5 minutes to do a carpal tunnel release, and it's really very life-changing.
Excellent. So actually that's a good point, because different treating physicians, address it different ways. I'm one of those people who I would like to try one injection unless I have a real reason not to do that, because to my mind, it may be just me, I want to know that I tried one thing before I took the patient to the OR. So let me ask Harry, do you try injections? Do you avoid them? Do you choose who to give an injection to or not? How do you handle injections?
Yeah, so it can be very regional as well. There's certain parts of the country, as we're going to have a lot of people listening to this, is that in some areas, injections are expected as a sort of non-operative. In other words, try something that's not surgery. In some areas, it's the surgery is the primary focus. What I would like to know is, if I could, is this in the mild or early stages? Is this something that just occurred because you were doing something repetitive for a little bit, and I might be able to get you back to what your baseline was? And if I knew that, or if I could help the diagnosis of something that's mild compression, in other words, the nerve's not permanently affected, then I believe that an injection could be quite helpful. It is then on us to try to decide, how do I rate somebody, or how to determine if you're mild, moderate, severe, right? Because once there's some permanent changes occurring in the nerve, the best way to prevent the changes from progressing, as well as reverse some of these things, is decompressing the nerve surgically.
Thank you. Thank you. So let me go back to Dr. Mercer about the surgery. It seems there are different ways to do it. Can you explain to us the different approaches, and more recently, where do actually people get the surgery? Classically, they used to be put to sleep in the operating room and, spend the day there. There are different ways now. So can you brief us a little bit at what's new with carpal tunnel surgery in different manners?
Sure thing. I just had one more comment about the injections before we move on. One situation where I think the injections are very helpful are in situations of inflammatory arthritis. So somebody with rheumatoid, lupus, Sjogren's, Crest syndrome, there's a whole list of them, psoriatic arthritis. Because these tend to be inflammatory problems, oftentimes an injection can be helpful because it quiets down the inflammation, which ultimately shrinks the amount of tissue that's in the carpal tunnel, and your symptoms get better. For me, if I'm going to inject the carpal tunnel, even though I do 10 of these procedures in a given day, I send them to Dr. Barr to do them with ultrasound, because I think that making sure that you don't impale the nerve, that you get it in the right spot, that you have somebody that's very, very careful and meticulous with the needle direction, I think is very important. With respect to surgical intervention, typically, again, as Dr. Hoyen mentioned, this is very regional. And in our sort of little microcosm of orthopedic hand surgery, we do the majority of these with a regional block, and it's usually what we call an axillary block. So it numbs at the level of the shoulder, and it numbs your hand. We do a very short-acting block, so it takes about 90 minutes before that medication wears off and you get the use of your hand back. Some people do these under just straight local anesthesia, where you infiltrate or inject a bunch of local numbing medicine around the area where you're going to operate, right there where Dr. Hoyen is showing, and then they do the operation. That works perfectly fine as well. Then and it goes all the way to general anesthesia, which I think is being done less and less for this procedure, because it's not a big operation. It's not like you're having a total joint surgery, even though, like, in this day and age, even total joint surgeries are being done under spinal anesthesia. With respect to the way that you release the carpal tunnel, there's really open procedures, and then procedures that are facilitated by visualization that is not like opening up the skin like a book. So my preferred technique is a mini open technique, where you make about 1.5 centimeter incision directly over the carpal tunnel. It takes me, minutes to do this operation. So it goes right there, right where he's showing at the level of the palm. And it works very well, and it's very safe because you can see all the structures very clearly. You can see the nerve, you can see the tendons. Every once in a while you see the motor branch, but you don't necessarily look for it because you know that it's to the radial side or the thumb side of the incision, and you can stay away from it. And so to me, it's a very safe way to do it. I also do endoscopic because sometimes patients want to have it done endoscopically. Sometimes endoscopic is indicated. For example, in settings of fracture, like distal radius fractures, sometimes it's a little bit easier to do it endoscopically than it is to do it open. And so in that situation, you basically, the incision length is the same. I think that the misconception is that the incision size for an endoscopic is smaller than the incision for an open procedure, and it's not. And oftentimes I see endoscopic incisions that are twice as big as the ones that I make, because they have to get into the palmar fascia to release it. But the endoscopic procedure is perfectly acceptable. It works very well as well.
Thank you.
There are addition. Yes, I think that we should talk about a few other things. So in addition to that, we have ultrasound guided and all these other things that are sort of being developed, but have not been fully sort of vetted. And so again, people are trying to figure out the best way and the smartest way and the easiest way. And so you'll see all different sort of slight modifications of this, but I think that the tried and true way of having a carpal tunnel release is a mini open incision, which is about 1.5 centimeters, or an endoscopic procedure, again, by somebody that is well-versed in that procedure.
Thank you. The only thing I can add to this is the venue where you actually get the surgery done. Classically, it was done in the main operating room, like you said, under general anesthetic. And then, with time, they start happening in the ambulatory surgery centers. And the more recent development is actually doing it in the office, which is what I do most of the time. And, more than 9 out of 10 patients, I just do it in the office. I am privileged to have a room set up as an operating room in my office. And I think it's picking up. Harry, do you have any experience with office surgery, or do you have any partners who do that?
Yeah. So, I think the key to this, and we just take one step backwards, is that this is that tunnel, right? And we're opening that tunnel, right? And then the tunnel kind of heals back again. And however you think you can visualize as a provider the tunnel the best, that's the way to do it. And then the second part is, as long as you have a good, safe environment to do that. We have a procedure room, and for some individuals who want to do this with just a local anesthetic versus the whole arm being numb, that's a good viable option. The nice thing is that we have really good results with lots of different ways to release the carpal tunnel, and as long as you're seeing someone who feels rather comfortable and they do sort of the same drill, I'll agree to disagree with some of the other people. If I would like Dr. Siraj to do it the way he does it and does it the best, and then when I'll get my left hand done in New Mexico the way Dr. Mercer does it and the way she does it best. So this is the good thing for the patients. It's well studied. We have good techniques, and it's nice to have a little bit of controversy, but I don't want to say that, my way is the best or someone else's way is the best, as long as you do it in a good, safe, clean environment.
Excellent, excellent. So let me ask Dr. Bar, what if somebody truly neglected this for a very long time? What do you tell them before surgery or after they had surgery and they're not happy and they come back, you say, hey, I had my surgery, still having issues. What do you tell them?
Well, I think unfortunately, sometimes people have nerve damage. So if you look at the literature, even if you have severe nerve damage, your symptoms are likely going to improve with surgery, but it might not be cured. And so that's what we'll see. We'll see some improvement. And it's funny because sometimes when things are better but not cured, you sort of forget how bad they were. I think that's a good coping mechanism, right? We don't dwell on how bad we were suffering in the past, but sometimes people's expectations, I think, are overblown if they've let it go and get too much nerve damage. And that's one of the things I think you can really tell that electrodiagnostically if you're starting to see some nerve damage. And I'll really counsel patients to get it taken care of, because there are certain people that they're very good copers, and they said, I can live with this. And just because you can live with something doesn't mean you should live with it. And you could be thinking you're helping yourself. I'm just going to cope with it. And you're actually hurting yourself. And there's a lot, I think, of expectations like that they'll have to take weeks off of work if they get a surgery, or that it's very dangerous and risky, and so people put it off too long, and they can still get improvements with surgery, but unfortunately sometimes there's just been so much damage it can't be fixed.
Thank you.
Yeah, Shafiq, that's interesting, because in this data-driven world, we're all about data, AI data, right? So I have many patients that come in with an electrodiagnostic study for us to review, and that gets to a little bit of expectations, because there's two parts to this study, as Dr. Barr mentioned. One tells you sort of the speed of the nerve, and then the other one tells you the spike of the nerve. If you can imagine, a good nerve spikes all the way up, right? And a diseased nerve, doesn't spike as much. And for some people that are sort of, let's say, on the fence or data driven, you can show, listen, your nerve's going 20 miles per hour, whereas the other one's going 40, or your nerve should have a spike of 10. And look at your nerve, the best it gets is 2. I just give an example. And so it can help some people that are data driven in this world to go over some of those things, so they understand it as part of the whole thing.
Wonderful. it seems we were starting to get into a little bit of controversy here and there. So then my next question is, how do you manage patients after surgery? Dr. Barr mentioned, taking a week off. Is week enough? Is it too much? Is it too little? So different surgeons do different things. They have different considerations. So I'll start with Dr. Mercer. What do you tell patients after your carpal tunnel surgery? You just finished, they're in your recovery room, or they're just leaving. What do you allow them? What do you not allow them? For how long?
So it's interesting how things evolve over time, right? So when I was doing fellowship, which is now quite a long time ago, we would put patients in these big splints and these big dressings and things between the fingers. And now I literally apply a Band-Aid. And my closure is with monocryl, so it's a subcuticular closure. I put a little bit of Dermabond, which kind of seals the incision, and then I put a Band-Aid on there. And I have patients immediately move their fingers, immediately move their wrists, and the only restriction that they have is not to lift anything greater than 5 pounds, because it's just going to hurt, right? I just opened up the skin and I mucked around in there, and then I closed it up. And so ideally, you don't do anything aggressive for 2 weeks. After that, you can pretty much do everything. I do counsel about, some weakness in the hand, because it's perceived weakness because you've just had surgery. That typically doesn't resolve up until about the 3-month mark, where people start to feel like their strength is coming back. In terms of going back to aggressive activities, I say just go back gradually. Every person is different, right? So I have a surgeon that comes to me that wants both carpal tunnels done tomorrow, and then they're going to go to work tomorrow afternoon, right? So different people have different motivations, and then you have other people that take a little longer. So it's very, very individual dependent. But I think probably the max is about, and I don't want to give anything like a definitive number, but like 6 weeks is probably the upper limit of a long time for recovery. And not saying that, some people maybe take a little bit longer than that, but I would say that probably the minimum is 2 days to 2 weeks, and then the maximum is like 6 weeks, maybe to 8 weeks. And maybe Dr. Hoyen can add some insight to that timeline.
Yeah, that's a good segue. And, it takes a couple weeks just to make sure the wound doesn't pop open again, right? So that's what I tell everyone. Just to, you can move your hands and fingers. And Dr. Mercer mentioned some of these things about nerve gliding and how important those are after surgery as well as before surgery. I used to sort of underestimate how long it took for that incision in the palm. And having lived with 2 parents who have had carpal tunnel releases, I'm impressed on how long it takes to get back to full. Not picking up a gallon of milk without thinking about it, using a hammer, mowing the lawn. Those are pretty heavy duty things. And if you cut yourself, it takes a little bit. So I've changed my tune a little bit over the years, from personal experience. And I'm with Dr. Mercer. Take it easy for a couple of weeks, then go ahead and use it, and let common sense be your guide. But don't be too alarmed that, in a month or so, you're still like, God, I want to drill. I want to put drill, I want to put my, thing in all the time. Well, it takes a little bit to heal. But the important part is that sometimes, and our group will say, is that they'll get the call afterwards, or you see them in a week or two, and that nighttime pain is gone. Right. I can feel a little bit already. And one of the things which we'll probably get into is that, how long does it take for this nerve to get better? But a lot of those really intense symptoms that they're keeping you up at night, and you experience during pregnancy, as we had mentioned, and those sort of things. A lot of times, and I don't want to say 100% because nothing's 100%, but a fair amount of the times, those things are gone away early.
I think one other thing to be aware of, which is super common, is pillar pain, right? So you have pain right here. So you're pushing yourself out of a chair, it hurts. You're pushing a door open, it hurts. And that is the nature of the beast, right? You've got, Dr. Hoyen mentioned, you have this tight tunnel, and then you open up those tissues, and then they heal. And then the top is healed with scar tissue, because, the body heals with scar unless it's bone. But in general, the body heals with scar. And so that scar has to remodel. The remodeling takes time. And the pillar pain, as we call it, is something that you should anticipate having for many months. But it just keeps getting better. So initially it's sore, and then it's just less and less and less sore until it's completely gone. And the pillar pain is there no matter if you have an open carpal tunnel release or an endoscopic carpal tunnel release or some other, some other way that they're visualizing the nerve to release a carpal tunnel. It's present because the tissue that's scarred over is a transverse carpal ligament.
Yeah, we have a little internal study in our house. I've had one parent have an endoscopic and one have a small open, in full disclosure, not done by me. And the recovery was pretty darn similar. Maybe a little bit earlier, but I was pretty impressed on this sort of long-term recovery was pretty darn similar.
Excellent, thank you. I just want to throw in a little bit clarification for the benefit of our audience. Dr. Mercer mentioned monocryl. Monocryl is an absorbable suture. It usually lasts around 5 weeks for it to dissolve spontaneously. She also mentioned Dermabond. Dermabond is really the super glue of surgery. And having said that, do not use actual super glue. I had somebody come in putting super glue on his stitches, so don't do that. So with that, any other last remarks, Dr. Barr, Dr. Mercer, Dr. Hoyen, for the benefit of the audience?
Yeah, I'll start. One of the things which we didn't cover a little bit is that if you have this sort of mild, moderate, or severe carpal tunnel, what can you expect, right? And so in severe cases where the nerve has been permanently altered by the long-term compression, the individuals might not get all the sensation back that they had when they were younger or before this occurred. So in those severe situations, you get some recovery, that pain or some of that buzzing feeling gets better, but sometimes it doesn't fully recover. We have really good data because thousands and thousands of these have been done, that the recovery kind of incrementally gets better, and even if it is severe, you still get a lot of the relief of those symptoms. Sometimes if it's really mild, some of those people get good relief, but again, they might not get as full. So the good news is that surgery is very successful, but the reality is, and Dr. Mercer said this, is that the nerve is a very finicky structure, and it doesn't always respond like we thought it would. So I really counsel individuals to say, listen, this is going to be better, but it might not be normal.
Thank you. Dr. Barr, anything you want to add? Or Dr.
I think
Mercer?
I would just, tell people that if they have, electrodiagnostically or ultrasound proven carpal tunnel and it's beyond the very mildest range, just get it taken care of. It really makes me sad. I've seen people, I do a study, life gets in the way. They're sort of afraid of getting the surgery. They come back 2 years later. Now they're in a much worse situation. And it makes me really sad because it was so avoidable. So I think my big take home point is just don't ignore it forever. Just get it taken care of. You'll be so happy that it's done and you won't worry about getting more damage.
Very well said. Dr. Mercer?
Yes, one other thing is relating to the incision, the palm of the hand has a ton of dead skin. And so the incision always peels. And this is something that I get asked about 100 times a month. Well, my wound is opening. Well, what's happening is that you're sloughing the dead skin off the palm of your hand. And so just something to be prepared for if you end up having to have your carpal tunnel released is that as a result of the incision, you will have peeling. And I call it the stellate Africa, right? Always looks like Africa to me for some reason, right? So you get this sort of pattern of peel, almost like a blister. And most everybody get that type of peeling. Doesn't matter if you have, monocryl suture, which is the absorbable suture, or sutures that have to be removed. This is something to expect and happens in every single situation.
Yeah, that's a good point, Dr. Mercer. And I think with any incision or any wound, it's important for the individual who's had surgery is to modulate or improve their own scar, right? And we have lots of ways to do that. We have certain creams. We can rub the area. That scar gets very hard because let's face it, the palmar skin is very thick. And one of the things that's really important after surgery, and anyone who's either had surgery that's listening to this or contemplating it, is really get that scar the best you can, afterwards. And that skin will start to peel, and then as it does that, get that that incisional scar as soft as you can, because that will help some of these other things later on. Because individuals and patients always ask, well, what can I do? And those are one of the, I think, one of those important things that the individual can do.
Excellent. So with this, we reach the end of this fireside chat. I thank all our participants for their insights, and our technical and administrative team who have been working behind the scenes to make this session a reality. I also thank our audience for their attention and hope we were able to clarify some of the questions and concerns you may have related to carpal tunnel syndrome. Please be advised that the information provided here is not intended to replace proper evaluation and treatment by your physician, and is only offered as an educational tool to make you better prepared for your visit. Millions of people worldwide live with peripheral nerve conditions that could be treated to improve their quality of life or regain function of an extremity. The Global Nerve Foundation is working with doctors, researchers, and patient advocacy groups across the world to raise awareness, aiming towards fulfilling its vision of advancing and promoting excellence in nerve care worldwide. Goodbye, and thank you so much.